So we are ready. So, well, when technology works, stays brilliant. But in most of the time, we have all sorts of problems, and hybrid meetings are not the best. So I'll just standing up so that I can just see all of you, and I can just understand if I lose you at some point during my presentation. So that would be the best for all of us. So my name is Ayşe, Ayşe Erek, and we are here to make a presentation about our past work and to explain how we are intending to move forward in the near future with George Triftares. He's a professor in our research project. I'm a research fellow at Heriot University. We are both coming from the same university. And so let me just start talking about our work. So the title of the presentation is Exploring Key Drivers in Cancer Risk, Unveiling Disparities. So I'll be talking about cancer risk and cancer inequalities in general by referring a number of different studies. So that is why we have this general title, and this is a collaborative effort. This is a teamwork. We have 5 more people apart from me. George is already here, and we have someone from your team as well, Adam. So Adam also joined the last part of this work. We have a funding from SCOR Foundation for Science, but we also have funding from Society of Actuaries. And okay, I can just change this. Here we go. Is this working? Okay, and the presentation I'll be making today has 3 main parts. I'll start talking about what we have done in the past year, and I'll also describe our recent work that is about to be finished. Later, I'll be talking about a new data set we acquired from Office for National Statistics. Apologies. And last part is about how to move forward. We'll be referring a couple of new research teams to see how we can take this whole project idea together, hopefully. Let me summarize what we did with SCOR Foundation for Science. So this is about our funded project, and this will be a very quick summary so that we can just provide the full big picture to all of you. So we worked on breast cancer risk, to be specific, as part of our funded project. And this was because breast cancer is the most common cancer diagnosed in women, and also it is still one of the leading causes of death. And on top of all this too, this is also one of the most common conditions among critical illness insurance claims. So we had 2 specific purposes here. One was to investigate how a major disruption to health services caused by catastrophic events such as the COVID-19 pandemic would impact breast cancer diagnosis and also breast cancer mortality in general. And the second purpose of our research was to see the models we developed as part of this first aim, to see how these models could be implemented in the context of life insurance and critical illness insurance products. So what we have done as part of these 2 aims, we developed a 6-state Markov and semi-Markov model. And I'm not planning to just go through the technical details of this model, because we already talked about this model in the last visit in September in details. And also we gave a webinar about this. But what I would like to highlight about this modeling setting is the strengths of the model, basically. So this modeling setting has 3 main strengths. One is the modeling setting is distinguishing between different cancer stages, like pre-metastatic and metastatic breast cancer, where the latter is being the last stage of breast cancer. And the second advantage of the model is we are accounting for untreated and undiagnosed breast cancer cases through a certain parameterization. And the third strength of the model is we are capable of creating certain scenarios linked to breast cancer diagnosis and treatment. So based on this modeling setting and following these trends, we produced 3 main outputs as part of this project. One is a published conference paper. We have a paper under minor revision with Scandinavian Actuarial Journal, And we have a working paper that will be submitted soon. And as part of these 3 studies, what we have shown is the value of such modeling setting. And we are showing how to calibrate this model in the absence of a comprehensive data, which is most of the case we are encountering. So we are showing how to do this by accounting for available public information and also thinking about available medical literature. And as a result, we quantified breast cancer incidence, mortality by stage, breast cancer mortality, as mentioned, and also other cause mortality. And what we found, one of the main findings, is related to pre-pandemic and post-pandemic calibrations in the lines of COVID-19 pandemic. And we are showing, as a result of initial health disruptions caused by the COVID-19 pandemic, we would observe 3 to 6% increase in breast cancer mortality between old age groups, referring to age 65 to 89. And we also show that the same amount of interruption would cause a 5 to 8% increase in deaths from other causes at the same age groups. We also quantify years of life expectancy lost by using the same modeling setting by creating different scenarios using our parameterization in the modeling. And later we are showing how these models we developed could be relevant to medical underwriting of related insurance contracts. And we further show how our model differs compared to an industry-based model and what are the advantages of using this model, basically. And as part of the whole big picture, we are showing the significance of duration dependence in the lines of semi-Markov model. Now, before moving on, may I ask if you have any questions? Go on.
For the comparison between pre-pandemic, you're comparing which year? During the pandemic years or?
During the pandemic years for about a 5-year period, starting from 2020.
And then in the model projection, are you projecting the same increase or you will be decreasing this?
So what we have done, we introduced a decrease in breast cancer diagnosis throughout our parameterization, and we are running some simulations. And we are keeping the pre-pandemic calibration apart from this change in the post-pandemic scenario. And then we are just comparing these 2 scenarios. And the difference is leading to the numbers you are seeing here.
Yeah, okay. But then for the future projection, are you keeping the same increase during the pandemic years, or you're going to decrease it because the impact from pandemic is less?
So we are assuming the impact of the pandemic is the initial disruption. This is only relevant for the first 9 of 2020.
Yeah, okay.
So that is the only change. We are not assuming a decrease would continue for about 5 years or longer. It's just really the initial disruption. Yes.
Another question about your semi-Markov model.
Yeah. Do you want me to go back to the model?
Yes.
Here we go. So this is the mark.
You can go from the state, the free metastatic diagnosis. You don't observe directly from no-BC to metastatic diagnosis.
That's correct. Well, that is nicely said. So while in practice, the metastatic cancer diagnosis right ahead, although these are rare, but we didn't assume this is happening as part of this modeling because of absence of the data. Okay. So as part of this modeling, if I can just step through, because of the existence of this state 2, we are accounting for unobserved breast cancer cases. And indirectly, as part of this modeling, we are also accounting untreated breast cancer cases. So these 2 are not observable to begin with.
So yes,
and so what we are doing is basically to set a simple but smart model that could quantify both impacts indirectly speaking, and introducing a transition from 0 to 3 basically increased complexity in the absence of data. We decided to keep it simple, to keep it interpretable.
Okay. And for no-BC, finally, there is you can, for the next, you can stay on no-BC, the majority.
Yes.
Yes.
That's
okay, I understand. Thank you.
You're welcome. Any other questions before I move on? Okay, then I'll just move towards the second part of the presentation. So while this part of the projection, some part of it has been already presented by George in September. So you might recall some of the ideas from that presentation. I'll then explain the differences between that presentation and what I'm doing here. So first I need to introduce a new set of data here. And this is to explain how we link our funded project to another ongoing work. So these are in the similar lines, and we'll also refer to COVID-19 related excess deaths as part of this research too. So what we are doing here is based on population data. We are using the population data of England. The data is provided by Office for National Statistics. So this is an aggregated data. And what we have is some interesting information apart from the usual demographic information, such as age, gender, and year. We have two additional information as part of this data. One is region information, 9 regions of England, changing from the north towards the south of England. And we also have deprivation information. Here, deprivation is linked to multiple deprivation index 2015, which has the 7 domains to describe relative deprivation on a national level in England. But what we are specifically referring here is income deprivation. And we have 10 levels as part of this variable, where level 1 is showing us the most deprived 10% of the population we are looking at, and level 10 is showing us the least deprived 10% of the given population in a given region, age group, and so on. We have 5-year age groups. We have single years from 2001 to 2018. I'll be referring cancer mortality data from this moment onwards. And we have some information up to 2022, but this is for higher level data rather than having the same granularity. And as part of this part of the study, I will be referring some cancer mortality projection as well. And there I will be referring quintiles, income deprivation quintiles rather than deciles. And quintile will refer to 20% of the population, where level 1 will be showing the most deprived and level 5 will be showing us the least deprived 20% of the subpopulation. So it's not changing. Here we go. Yes. So what I need to explain you to begin with, in order to explain the projection work, first I need to explain you what type of modeling we use to begin with and why we thought about this model. So in 2021, we made a publication, and in that publication, we are talking about cancer inequalities, cancer trends and cancer inequalities in regions and deprivation levels of England. And this was part of George's talk back in September. So there we referred a Bayesian hierarchical model presented here as well. And in this modeling setting, the aim has been to smooth cancer rates in different regions and deprivation levels of England by accounting all those risk factors altogether. And we applied type-specific cancer modeling, and we looked into major cancer types along with all cancer type, both in cancer incidence and cancer mortality level. So in this modeling, we are thinking a +1 log normal type hierarchical model. We are assuming cancer counts, which can be either cancer death, type-specific cancer death, or type-specific cancer registration, as we have both in the data, follow a pattern distribution with a mean parameter multiplied, where this cancer rates multiplied with mid-year population estimates. So these are denoted by theta and E in the model, if I can highlight here perhaps. So I'm referring these two variables. So then we are assuming type-specific cancer rates denoted by theta follow a log normal distribution with these two parameters mu and sigma square. And each type-specific cancer incidence or mortality modeling, we are assuming the scale parameter sigma is following an inverse gamma distribution, non-informative, and then we are describing the parameter mu for each type-specific cancer in a specific way. We are doing a certain variable selection, and there we are doing a forward variable selection by accounting for variance information criteria Bayes factor, and so on, to see if we can only account for statistically significant variables to establish a sound model. So here you see some subscripts, and these subscripts are referring the main variables coming from the data. Here, A is standing for age, T is for time or period, B is for the duration, J is for gender, and R is the region variables in the data. We are introducing all these main variables as main covariates into our modeling, and also we are accounting for two-way interaction terms to address nonlinear relationships between these variables as well. So the difference between cancer incidence and cancer mortality modeling we carried out. We have one additional main variable in cancer mortality modeling, what we called as here average age at diagnosis, AAD. Now this variable is an artificial main variable we created, and this variable is coming from cancer morbidity data to feed cancer mortality modeling. I'll explain what this variable is and how we are using this, but at the minute, just keep in mind, we have one additional main variable, and we'll be using this to create some scenarios. At a later stage, I'll explain this. Yes.
I have one question.
Go ahead.
How do you consider in the model stage 0 cancer or carcinoma in situ? Is it non-metastatic cancer or is it healthy?
So as part of this modeling, we don't have cancer stage. And this modeling structure is just to establish, to address population cancer incidence mortality, where we don't know at which stage these people are diagnosed with cancer or
but you
die.
need to, do you have considered stage 0 as number of cancer registration as a CA, or is it censored and still healthy? And you have nothing about carcinoma.
C is cancer registrations. If it is, it can be cancer registrations or cancer deaths. If it is cancer registrations, is just showing the diagnosis of cancer in the population data, but we have no information whether this is at the last stage or the first stage of cancer.
Yeah, the problem is the word cancer. Is the carcinoma in situ for you a cancer, or is it a non-cancer?
We are only considering cancer cases here. So if it is registered according to the National Health Service in the UK.
Because the ONS does register carcinoma in situ as stage 0.
Yeah, so we're using ONS data.
Yeah.
So this is if cancers are registered according to that definition.
It can
so
be
this is our cancer data. So so these are people with cancer, and we don't distinguish any further between different stages.
Okay, but the ONS does distinguish between.
They started to distinguish from 2012. So apologies. So they started to distinguish from 2012 onwards, but it is not in the same granularity, or they are not releasing the data.
They do still have it because it's a different ICD-10 code. So the one is the C code and the other one is.
They are using ICD-10 code for the data we use. So they didn't they didn't compile the data by cancer stage. They only have it, as far as I know, as between 2012 and 2017. They did some information by cancer stage on a very high level, and from 2019 onwards they just stopped dealing with cancer registrations. They just transferred the data or this responsibility to Public Health England, then Public Health England then just sent the responsibility to NHS. So it just complicated after 2018. So if perhaps ONS dealt with the data, I'm sure now at this time they would have had something, but they stopped doing it. So I don't know if the other institutions are just publishing.
Okay, so you know what happened with the care chapter. So carcinoma in situ of the breast is, I think, P6. I'm terrible with numbers and things like this.
I think it's just a C code.
It's just the C code, right? Okay.
Yeah.
Another question. Let me just continue. I'll only have a couple of slides to explain what we meant with cancer inequalities, because this is one thing I'll be referring in cancer prediction as well. So I have two slides referring to breast cancer mortality and lung cancer mortality. What we are looking at as breast cancer mortality, both age standardized fitted breast cancer mortality in regions of England in 2018 to be specific. And the data, the presentation is not split by deprivation. This is because we haven't found income deprivation to be significant to explain differences in breast cancer mortality. That's why we only look at regional inequality in this plot. And as you see, the rates are quite close to each other. We have different shades of purple representing different numbers in different regions. And darker colors here are showing higher breast cancer mortality, meaning we have higher breast cancer mortality in the southern regions of England compared to the northern regions of England. So if I move on, the next figure is showing us something related to the lung cancer mortality. Again, we are looking at age standardized fitted lung cancer mortality. This is for women in 2017. Different than the previous graph, we now have deprivation information because income deprivation was significant to explain differences in lung cancer mortality together with region and other demographic information. And in this graph, we have two information, region and deprivation. And when you first look at the graph, it's a bit confusing to get what is what. So this is because we only have one dot to represent both rates in a given region. But the point is to highlight the deprivation gap in each region. So to show this, what we are looking at as the most deprived rate on the x-axis and least deprived rate on the y-axis, and you see an equality line here. So this means if the rates in a given region were equal to each other, then we would expect them to appear on the equality line that would show equality. But the rates are below the equality line, showing actually the higher lung cancer mortality in each region happen to be in the most deprived deciles of a given region. So this means that, for instance, if we, and you see we have different numbers like 2.5, 3, and 4, the parallel lines. This is to highlight the gap between the rates in the highest and least deprived groups. If you look at Northwest here, this means the number there is showing us a woman living in the most deprived decile or most deprived neighborhoods of the Northwest of England is more than 3 times more likely to die from lung cancer compared to a woman or women in general living in the least deprived deciles of the same region. And the numbers here, like these 2.5, 3, and 4, they are not really sort of random, because lung cancer is different than breast cancer. And this cancer type is considered like a lifestyle cancer. However, I shall be careful with my wording. So with lifestyle cancer, we mean a cancer type with more controllable risk factors, such as smoking. So it is not necessarily the relationship between lung cancer and smoking. And ONS has really informative reports. And one of the surveys they reported showed that people living in the most deprived neighborhoods of England are more than 4 times more likely to smoke compared to the people living in the least deprived. So as you see, what we just quantified as the gap is very close to 4:2. So this is also highlighting the importance of controllable risk factors to be considered as part of our modeling, which we didn't do as part of this modeling. But we managed to bring this up in our projection. So if I just briefly summarize then what we learned or what sorts of insights we gained by studying all this data based on this particular modeling structure, as in general, we see we have higher type-specific cancer morbidity or mortality at older age groups, perhaps as expected, but this seems to be perhaps changing. This might be changing in the future, according to the recent newspaper articles. As you see, there are some concerns about the surge in cancer under age 50. So this is something to keep in mind. In our published work, in our modeling, we have seen mostly a increasing trend in cancer morbidity, a decreasing trend in cancer mortality. There are exceptions like lung cancer in women, but this is mostly the norm. We also see mostly high rates for women in general compared to for men is compared to women, and we see regional inequality exists in all cancer types we looked into. This includes prostate cancer, bowel cancer, lung cancer, all cancer, and breast cancer. And meanwhile, we see socioeconomic differences matter when it comes to lifestyle cancers in general, and also it is relevant to type-specific cancer morbidity, such as breast cancer morbidity on neighborhood level. So may I ask if you have any questions so far? Yeah.
So, so the regions that you've got in here correspond pretty well with the ICS regions for the NHS.
Mm.
Did you put in anything about the waiting lists by the regions? Because to me, I'm just wondering which thing comes first. Is it okay, they're lifestyle cancers, but actually, are you just seeing the people with higher socioeconomics see the waiting list and then go private insurance?
Yeah, that's true. So we didn't do it as part of this modeling
Okay.
yet. We didn't just wait fast, but this is one of the things we are considering as a future work. So as well say that's true. So it's not the same thing being poor in the southeast of England and being poor in the northwest of England.
Just
Yeah.
one question from my point of view. What is important to view from the client perspective, for example, for life insurance? We are just focusing on the top of the income or wealth, generally speaking, distribution, but therefore less deprived people. Of course, we are getting some rights for the different regions. And how would it be reliable to assume, for example, there is a rate of cancer which is typically for a certain upper part of the society, and the second one for the lower part of the society, and I can try using your data, put a linear program and extract a certain value. How could this value be reliable in fact? Because it's just an implicit value I can impute to the different level of wills, at least two, even more, because we have more data and we could, of course, better, more distinction. But maybe there are differences, of course, for the same level of wills in the different region, because the infrastructure are not similar, etc., etc.
Yeah, that's a good point. So if I may
Go on.
start. That's a very good point. I mean, in our model, we are accounting for both region and socioeconomic factors. And of course, there are a lot of different things in socioeconomic factors. We are taking one index of socioeconomic distinction, if you like, using the income deprivation, but there are other indices and other factors that somebody can take into account. So in terms of how reliable that is, I mean, our model is as reliable as the data are. We cannot be more reliable than, we cannot add more reliability to the data, but we do add uncertainty. So our estimates come with probability intervals and so on. And I think this is part of what you're asking, if I understand this correctly. One issue there is, and I'm going to talk a little bit about this later, how do you distinguish between aggregated level data, such as these ones? So what we're using is an index of deprivation for a whole area. How do you distinguish between that and individual level data? And this is somewhere that an area which you can use to start getting more personalized results. Whether or not this is applicable to insurance, I don't know. You can tell me.
That's just.
I don't know if insurance can be allowed to go down that level, but that's they use in the UK postcode, for example. But individual data, I don't know. But our model, what we're planning to do is to contrast the results that we would get with this type of data, which is aggregated level, to more individual level data, and see how this issue of reliability that you mentioned, Philip, may come in.
You haven't.
We have some individual data sources, and Aisha is going to talk about it in a
This
later on
is the
today.
new data we acquired, the data we are intending to
So, yeah.
study on.
Thank you.
Then I can perhaps continue talking about the projection model based on the same data. So still we will be talking about neighborhood level data apart from demographic information. So what we have done is to establish type-specific cancer mortality models using the same type or similar type Bayesian hierarchical model. We are still using, we'll be still relying on Poisson log normal type modeling. What is changing here is the definition of this mu parameter, which is the parameter of log normal distribution. Again, we are doing a variable selection here to see if the main queries we are intending to put are statistically significant, and if we need to add some interaction terms. Because one contribution we have made here is to project the cancer mortality on regions and deprivation levels of England. It is granular. So we needed to add some interaction terms to address differences in the granular data. Also, we are using, apart from this age, period, region, and deprivation information, provided we found average age at diagnosis information coming from morbidity data significant. We are adding this to the projection of cancer mortality, and this variable will be significant to create some pandemic-related scenarios. And on top of this, we are adding smoking information here. So this is one refinement we have made in the past months as well. So here, NS is standing for non-smoker prevalence rates. And as you see, we are adding this with a time lag into the data. So the time lag here is 20 years. So this means the smoking, well, the proxy we use for smoking, non-smoker prevalence is, let's say, to estimate the cancer mortality in 2001, we are using the non-smoker prevalence rates from 1981. So we also changed the definition of period effect here. All main variables are categorical variables in the modeling, and we are introducing a random walk with drift to describe the period effect by following the common tendency in the literature. And before showing you the general results, I would like to show what type of non-smoker prevalence rates we use. So as part of our data, we don't have smoking information. What we have done is to rely on some publicly available information. And if you just go, you'll see there are two sets of data related to smoking or non-smoker prevalence. So one is coming from annual population survey, and other data is from Health Survey of England. So the formal data is more detailed. It has like age, gender, and region type information. However, it is very restricted. It's starting from 2011 onwards. And the later data coming from Health Survey of England is just more comprehensive. However, it is more limited. So it has age and gender type information. While it is starting from 1993 going up until 2019, we decided to settle on this data to just avoid correlation type issues in the data and to avoid making further assumptions in our modeling. So what we have done here, what we are looking at now is non-smoker prevalence rates for men and women. One is on the left. For men and women, rates are on the right. We are looking at 4 main age groups between 45 to 75 plus. So the dots are showing the period rates, the data itself, and we applied a simple generalized linear type modeling here to just clean the noise in the data. And you see these estimated values to be solid lines. And if you look at the prevalence rates for men, we see just a steady increase in non-smoker prevalence here. However, we have a little bit mixed picture for women. You also see some dashed lines. So this is to reconstruct the data in the past years. Provided the modeling we would like to need more information which doesn't exist. That's why we use the modeling to reconstruct the values in the past years to embed those in our modeling. And before moving on, let me just tell you why we didn't use current or ex-smoker type information. This is because the definition of current and ex-smokers, they keep changing throughout the surveys. And this would add bias to the modeling. That's why we avoided it. We just settled on non-smoker prevalence as a proxy because it is the most consistent definition throughout time. So if I move on now, we'll be looking at 3 sets of results. The first one is for breast cancer mortality. So what we are looking at is age-specific breast cancer mortality from 2001 until 2036. So we are using the data between 2001 to 2018 as our true data set to make our fitted, to obtain the fitted values. And then we are just predicting the results from 2019 onwards up until 2036. We are looking at the results in all regions of England. It's selected age groups. The age groups I put here, we put here, they are corresponding to screening age groups in England. So breast cancer is available from age 45 to 73 in England. So we are just showing the differences across these age groups throughout the time. So also we are using the data in the most recent calendar years from 2019 to 2022 to show how good model is to capture the real data, to capture the observed data with the estimated credible intervals. So what we see is a generally decreasing trend in all age groups presented here. Perhaps one thing significant to highlight is even after 18 years in the future, we are seeing the rates are not overlapping in the oldest and youngest screening age groups, that they would remain different, significantly different from each other. And apart from this, one other thing to highlight is we haven't found average age at diagnosis to be significant as part of this modeling. This is because breast cancer mortality has equality. It has more equality compared to other cancer types such as lung cancer. So provided this and provided AAD is not significant, so I wouldn't show you the COVID-19 related scenarios as part of breast cancer mortality, but we'll be seeing such results for lung cancer. But apart from these 2 points, smoking is found to be significant to explain breast cancer mortality data. So, shall I continue? Do you have any questions? I see you have a question.
Yeah, on age of diagnosis, I would like to be, I would like, okay, so it's not significant.
But this is an average number. It is not the real age at diagnosis matching with the data. So this is a metric we created using morbidity data, and it is showing an average number across regions. And remember, if I just return back, if you just look at breast cancer mortality across regions of England, although region is a significant variable to explain differences here, you see they are only marginally different from each other. The rates are quite close, meaning when we produce a metric such as average age at diagnosis, representing or associated with this data, it shows little variability across different regions. That's why it is not being significant for projection part. That's the reason. Because it's not the authentic variable. It is one thing being introduced, and I'll explain how we are introducing it.
Well, it is still estimated by using the real data.
Real data.
It's an estimate. It's not an artificial variable. It's an estimate using the incidence data. But the reason why it's not significant in that particular model is because, as Aisha was explaining, if you account for different regions, different ages, and different socioeconomic factors, as we already do in the model, then AAD is not required in the model. So we're not saying that on an individual level, age of diagnosis is not significant for cancer mortality. That's a different question.
Yeah. I didn't mean it. Apologies. So thanks for just explaining it. This is not what I meant. It's just because of our modeling, because of our setting, and also you'll see how we are calculating AAD in a minute. It's because of the overall setup, basically. Yeah.
So just one question. So did you have to make an assumption on the future age diagnosis in your projection, or you?
So it is not part of breast cancer mortality anyways, but we are using it as an input, like as a numerical variable. when it comes to, for instance, lung cancer mortality. So it will be a variable split by deprivation and regions. We are assuming it would remain unchanged by region and deprivation in the future. That's the assumption we would keep there.
Based on the comment that I was expecting. Maybe.
Yeah, she
Same
intended
way
that.
that you consider for the prevalence of smoking, I guess you could have accounted for prevalence of screening, for example, or okay, there would have been.
So
but I
well,
guess
we didn't edit, but we thought about it. So we just made it.
I'll just say a little bit on that later on when we talk about the
future.
how we go forward from this future work. In what ISA is presenting, or in the work that we have done so far, we haven't used any screening or waiting times data, but we're planning to do so.
So the next slide is showing us how regional variation in breast cancer mortality would look like in the future. So in this graph, we are calculating a standardized fitted breast cancer mortality. So this is again from 2001 to 2036. So the solid lines are showing the fitted lines. So with credible intervals, you see the predicted changes in the future. So as you see, this is only marginally different across different regions. And this is actually a success because of the high breast cancer awareness and availability of breast cancer screening. So across different regions, we are expecting to see some regional variation, but at marginal level. So if I move on, the following two slides will be about lung cancer mortality. What we are looking at now is age-specific lung cancer mortality in men from 2001 to 2036. So here, you might recall that deprivation was significant to explain the data, and when we changed the modeling setting, it still remained to be significant in the existence of all other variables. And what we are looking at because of that is age-specific lung cancer mortality in men in selected regions of England. The northeast, the southeast of England are here. We also have London here. And apart from these regions, we have 3 levels of deprivation. So for the projection purposes, we aggregated deciles into quintiles. So we are referring the most deprived 20 percentile here with level 1, and level 5 is showing the least deprived 20 percentile in the population. So what we see in general with dots and lines, we have a general decreasing trend in men at the selected age group. So these age groups, 72 is referring the midpoint of the 5-year age group, 70 to 74. And 77 is showing the age group between 75 to 79. So these are 5-year age groups, not single age groups. So we see a generally decreasing trend, but in the future, they seem to be changing slightly. So the main update from this graph is basically the projected risk lung cancer mortality in men in the least and most deprived quintiles. They still remain significantly different from each other after 18 years, provided the confidence intervals are not overlapping. And if you look at individual regions, we see more into this. So if we look at, for instance, age 77 in the southeast of England, if you look at the most deprived quintile, you see in the feature. So in the most deprived quintile, people stop enjoying mortality improvement, so it's mostly latent. However, men in the least deprived quintile, so they still experience some mortality improvement in the future. So this is basically pointing a widening in deprivation gap. Whether or not this is significant, we will be looking into this in a minute. The following slide is showing how lung cancer mortality in women would change in the same regions at the same age groups. Again, the same deprivation quintiles. So different than previous graph, we see more regional variability here, just from the start. Because if you just compare the Northeast and London at both age groups, the London rates are more compressed. And this is more evident if you compare this graph with the previous one. where regional variability happen to be less. So we see women don't enjoy the same sort of mortality improvement in the past years anyways, and we expect to observe some increases at certain age groups, especially in the most deprived quintiles in regions of England. So there are different ways to quantify deprivation gap. We looked into a few different things. For this presentation, we settled on this metric. So we are presenting deprivation gap in terms of a relative mortality rate. So what we are looking at is a result of 8 standardized fitted mortality rates. So this is for women. We are basically comparing the rates in the most and least deprived quintiles. It's easy to interpret. And what we see from 2001 to 2018, the relative deprivation gap, or the relative mortality rate, if you like, this kept widening, and differences across different regions are significantly different from each other. So I hope you can just see the confidence intervals not overlapping, for instance, between the Northwest and London. And if you just project this in the future, relying on the projected rates, estimated rates, then we see the deprivation gap growing there. It persists. However, the differences across regions are just getting smaller, so they are overlapping. So impact of diagnosis delays on mortality, well, provided we have a quantity that would be related to age at diagnosis somewhat, this quantity allowed us to create certain scenarios. So since this is a parametric model, it is possible to change or play around with AAD variable to create different scenarios and then quantify the impact of tests on the overall mortality. So what we call average age at diagnosis, as mentioned, is coming from the type-specific cancer morbidity data. It is produced following 2 steps. In the first step, what we are doing is to weight age at diagnosis by using the fitted type-specific incidence rates along with a standard population. Then the end result is a variable split by year, deprivation, gender, and region. Then we are using this as an input. We are reweighting this variable by using the mid-year population estimates. This is now relevant to the population of England, to have an end result split by deprivation, region, and gender. So this is the variable used as an input in the mortality modeling, in the projection. And the way how this is put in the modeling, this is chosen to be a numerical variable having an estimate such as beta, showing if average age at diagnosis increases, then this would lead to an increase in the related type-specific mortality. So by relying on this variable, we assume there would be an increase in average age at diagnosis, let's say from 2020 onwards. So we wanted to relate this to the COVID-19 pandemic, provided cancer screening and treatments and everything had a halt in that year. So this sparked a fear of delays in cancer diagnosis, suggesting higher average age, higher age at diagnosis. So we tried to sort of mimic this. And to do this, we assumed an increase in AAD from 2020 onwards. So we are assuming the impact of an increase in this variable distributed over future years. And we are assuming that feature deprivation and regional structure would be unchanged in the projection model. And also to calculate excess mortality or excess deaths, we would need mid-year population estimates in the future years. So this is coming from the ONS. ONS already has projected population estimates by regions of England over the future years, but it is not split by deprivation. There we make an assumption, like the last year of observation, 2018, the deprivation structure, the distribution there in regions of England would be applicable to the future years. This is one assumption we made. Then we fit separate Bayesian models, separate models following our structure, saying what would happen if there could be an increase in AAD changing between 1 to 6 months. So we created 3 separate scenarios associated with 1 to 6 month increases in average age at diagnosis. And the difference between pre and post-pandemic estimates are establishing our existence. So we have 3 sets of results in this part. The first set is associated with lung cancer mortality in men. So what we are looking at age-specific increases in excess mortality. So we are looking at annual excess mortality, if you like, due to 1 month and 6-month diagnosis delays. 6-month diagnosis delays on the right. If you look at the scale on the y-axis, you see these delays are leading to significant increases in excess mortality. The results are for 100,000 people. So we are demonstrating the results with confidence intervals for age WSU between 45 to 89. The point is this excess mortality at each age group, they're significantly different from each other, and they are diminishing over the time because of our assumption put on the AAD. So we distributed the impact over time, assuming it would be diminished over time. So the second set of results here are associated with cumulative excess deaths. So what we are looking at is cumulative excess deaths for men and women. Women are on the left and men on the right, by regions of England. So these estimates are associated between 2020 and 2036. So we are looking at the results from 1 to 6 month delays. We see these are significantly different from each other in each region, provided the confidence intervals are not overlapping. And also we see the results are changing. They differ by region too. If you look at, for instance, I don't know, the East Midlands here, so this confidence intervals here are not overlapping with the ones in the South, suggesting they just remain to be significantly different. And if we just look at the total deaths as a result of 6-month diagnosis delays, we see the predicted results for women are about 10,000 for women, and then about 28,000 for men, with associated credible intervals here. Yes.
So the delay of 1 month, 6 months is supposed to be persistent in the projection.
So it is just like 1 month diagnosis delays, but the impact itself is distributed over time. So it is not like we are assuming 1 month delay happening in 2020, another 1 month delay in 2021. That's not the case. So we're assuming a compact impact just related to the projections. So the last plot in this part is associated with excess mortality by deprivation. So what we are presenting now again is at different years or the time, and we are looking at excess mortality for women. What we are presenting here is the estimated or projected deaths with and without the COVID impact, or with and without this delays on the numerator divided by the median population estimates in the denominator. So we are basically looking at this as a group, like deprivation 1 or 5 is referring to all people at all age groups in all regions, if you like. So we are looking at the difference and presenting this by considering the population estimates in England as well. So this mortality per 100,000 women. So the message here is we are expecting the lung cancer mortality in women by deprivation to be significantly different across the most and least deprived deciles over the time as a result of any source of increases in age at diagnosis. So if I just wrap this part up, and I hope you are still with me. I know this is a very long talk. So we found out regional and socioeconomic gap for cancer rates. And for some cancer types, such as lung cancer, so these gaps are widening. In England, both that's not always the case, such as breast cancer mortality or prostate cancer mortality. So we integrate the smoking type information into our modeling, and smoking is significant for both breast cancer and lung cancer mortality. COVID-related delays in diagnosis can lead to significant increases in cancer deaths. So this is quantified for lung cancer. And what we found as significantly different results by age, deprivation, and region. And our projection suggests persistent deprivation gap in lung cancer in future, whereas we see a marginal change in breast cancer mortality by region. So may I ask if you have any questions before I move?
I have a question, sorry, second question. Sorry, it's, go ahead. Yes, one of the main issue I have is like, why we're not looking at stage at diagnosis? Because that's the main reason why you're having a higher mortality rate rather than the age itself. Because age doesn't really matter if they delay by 1 year or 2. I mean, it doesn't really matter if they are diagnosed at stage 1. But in the process, if they develop from stage 1 to stage 2, that is really what reduces mortality.
Yeah, that's fair point. I think we wanted to do whatever we could have done with this current data, and we refined the model by involving age at diagnosis or smoking type information. But that's definitely where we are going. So as we'll be talking in the last part of the presentation, we'll be bringing like cancer stage screening, and individual or household level information into our modeling as well. So this data, although it is, I think, very good data, and it's providing some valuable information, is still restricted. And whatever we add, as you see, we need to find the data separately. We need to bring this up into our modeling. And this means we are looking at 2 different things at a time. And this caused a lot of issues in modeling too. For instance, when we were practicing with smoking information, we tried to use the more detailed data, but it caused a lot of inconsistencies and correlation issue, provided the information you already had in data. And you never know the source, how the data, the other data, alternative data collected. So we didn't want to dilute this data or overdo things with this data.
Can I just add to that? Because that's a very good point, and that's something that we have been thinking since the start of this work. The main thing why we haven't done it, the main reason, is because we don't have the data. And you will tell me there is data on that. I'm sure you will tell me that. But there is no data on that in the resolution that we want. Because we're looking at registrations of cancer, of death from cancer by age, region, year, deprivation group, and gender. Then if you wanted the stage on, and you would need to divide the numbers that you have by all these other 5 factors. We didn't find these data available. If these data are available and someone here is aware about where these data are available, that would be very useful. That's one thing. So that's the main reason why we don't have it in this part, in this work. The other thing, of course, is that we do have this in the work that Aisha presented at the start, the Markov modeling work.
Yes.
And just to give you the background, the order in which we did the work is the other way around. We first did this work, or started this work by looking at the differences in socioeconomic differences, projection into the future, and then we did the Markov. We moved into the Markov model. So in the Markov model that Aisha presented at the start, we are looking at different stages. So we're distinguishing between mainly pre-metastatic and metastatic.
Yeah, but again, there we didn't have that.
Again, the data are limited, but we are parameterizing the models based on available information, data, and literature information. So we do that there, and we have scenarios, COVID-related scenarios there. But again, it is what we want to do is to bring in that information where we can.
And if I make a bracket there, it's really problematic to get a hold of the data. I would like to give an example. I know you are tired, but perhaps this can refresh you up. So we asked the data between 2019 to 2022 for cancer registrations in the same resolution we have here. And we actually, in principle, secured the data for cancer registrations like at the same resolution up until the most recent calendar year in 2021. And this was when the cancer registrations data passed from ONS to Public Health England. Then in 6-month window, when we were trying to just place a secure environment to collect the data, Public Health England decided to just pass this responsibility to NHS. Then we just got lost in a kind of loop. Forever, we just secured the data, but we never managed to collect the data. I think NHS is still trying to just, I don't know, do some paperwork. So
Yeah,
this was
data not available, not in that resolution, and once you start asking for data in that resolution, you get problems with small numbers.
So it just got more difficult.
Identifiability and personalized data.
I mean, this was not the case before the pandemic, but even the same resolution after the pandemic became a problem. And also the further information is just very difficult to acquire. We just, I'll be presenting. If you don't have any question here, perhaps I can just move to the new data so that you can see. So we acquired the data. The data I'll be talking about, the new data. We secured the data in a year's time. And we spent another 6 months to just establish secure environment on paperwork to just reach the data. So it is just how difficult nowadays. I know you just are aware, you know, how difficult it is and how complicated things can go, basically. Any questions here?
Another question on smoking.
Yes. Do you want me to return back to the plot, perhaps?
It's fine. I mean, it's just a comments on.
Okay.
Because your smoking data is at population level, is a prevalence data, right?
Mm-hmm. This
So you're just mentioning the impact on smoking on the decreasing cancer mortality. But this one gives you, I don't know if you have heard about this called ecological balancing. It's like when you are looking at population level, if the two variables, no matter what, just non-related variables are changing in the same direction, you can easily find some correlation. But it doesn't mean that it can explain the changes in the other way.
That's why we did variable selection procedure.
Yeah.
So you are right.
The breast fat cancer, smoking is not real important perspective, and especially at population level. So there might be some issues it may due to other factors rather than smoking itself, but just by chance smoking is changing the same direction as the mortality rate. So
I understand.
there's something to get further.
That's a good point. So it is good to be aware of that.
Lung cancer is obvious because
it is obvious. Yeah, absolutely. But we found some medical literature.
Yeah. We actually had exactly the same thought. Obviously, the confounding issue in statistics is very well known that you get. I mean, that doesn't mean causation. We're not talking about cause and causal relationship here, but we are building a model where smoking could perhaps be an explanatory variable in terms of the model. So to explain why we see what we see, not meaning that that smoking causes any changes in breast cancer. So that's what our initial thought was, and our actually initial thought was not to include it because I wouldn't obviously think why these smoking prevalence should affect breast cancer, for example. And then we found some medical literature that suggested that, without explaining why, they found statistical associations between.
Much weaker compared with.
I don't know what the causal. I don't see the causal association here. But statistical association that has been shown
in some evidence.
A number of studies.
From the published studies to involve us, and we just did a variable selection to see whether it was worthy, and also we compared actually the results because this part of the research is related to my IOFA qualification too. We just looked at the results without smoking information, and involving this data into the modeling actually allowed lung cancer trends or projections to be just estimated more aligned with the recent calendar years. So it changed the trend slightly based on the last 10 years of the observation. So we just for breast cancer as well. Yes, for both.
From our previous book, smoking at population level is not a major risk factor for breast cancer, at least.
That sounds reasonable. We just found conflicting results in the literature and then more evidence about the statistical relevance in the recent literature.
So was that based on what your findings? Were they based on population data you said, or SCOR data? Population. No, so I'm just
I'll discuss this more.
Yeah, we don't have much risk factor data at all.
It's good to hear.
Sean has, I was gonna say Sean made a very good point.
Mm.
Maybe if you're open to further studies, maybe looking at the, for example, average menopause age.
Mm.
Actually, the main risk factor is actually the exposure to estrogen level in the whole lifetime. It's something that is really difficult to measure. I mean, unless you consider all these risk factors, especially those pollution from microplastic and all this, something that is impossible to measure. And there'll be some obvious corporate effect there that can be affecting the age structure. That if you look at single age, you will not see the corporate effect.
We didn't find it here in the data we are using. We didn't have the cohort impact.
So you can have the screening, you can have obesity, you can have basically some like the increased estrogen level at the population. All these are reduced birth rates.
Yes, it's true.
Yeah, and they are all contributing to this. So it might be a minor risk factor.
I think that the research we found, and I'm happy to pass it. So they were looking at this data, talking about the statistical significance in the case of accumulated impact of smoking, not like smoking for 1 year or 2 years, but for longer period.
It could be very significant, but if you look at population level, like reduction in smoking prevalence in women is not that large compared with men. It's like 1 or 2% per year, and this difference is not going to bring you a difference in cancer, breast cancer mortality that you will see in the data. It's too small. You are changing 1% of the population, and the impact of the smoking is still there, even they change to non-smokers. So the risk is not really reduced at population level.
But one difference here in what we are doing is that we are looking at that at a higher resolution compared to population data. So you mentioned 1 or 2% for the decrease in mortality prevalence. Sorry, not mortality. Smoking for women, but that's for the entire population. If you then start looking at this by age, by region, by deprivation level, then there are differences there. 1 or 2% is not uniform throughout the whole population, and that might cause that might cause this significance, statistical significance itself.
Yeah, I think at deprivation level, we definitely have some difference in smoking prevalence. I mean, that's.
I think we will just know better when we start looking into contrasting these results with the individual level modeling. So there we can just have a better understanding. Sorry, you have a question.
So I think it's good that you've got region, but I think something in my head that I'm still stuck on is you've got different ICSs within those regions that perform very differently in terms of their screening uptake, diagnostics rates, and then the one that's really important, I would say, is from referral to treatment time. And those are all stats that are available by each ICS. So it might be that, and there's a lot of ICSs, so then maybe it would get too granular, but there's no reason why you couldn't group the ICSs within the regions by how well they perform to some of those key stats. Because the ones that perform better, especially from referral to treatment, you're going to have better outcomes. Because, region, it makes it sound like it's a little bit like it's the individual, but really it's the access to treatment.
These are all neighborhood level information. Not really related to the individual.
Yeah, but I just wonder if that's a metric, because then if you think about the pre-pandemic, ICSs were where they were, but post-pandemic, during the pandemic, the level of disruption was incredibly different by those ICSs, even within the regions. So if you use region, it might just be a bit of a muck. And then afterwards, when you're projecting them, about how well they come back, I think. So it might be that some of those key metrics on performance by ICS, you could have good performers, mediocre performers, and
perhaps we can try to link such information to region somewhat.
Yeah, I think just by region though, you're good. There's so many ICSs within the regions that you'd have to. It should be easy enough to do by ICS.
So we need to just look at the data and see basically how to integrate it. So I can't just think right ahead how to put this into modeling. just provided we are thinking about a group of individuals, not one individual. So we need to find the right way, sort of.
Yeah, so you have just
putting this.
the exact same data, you just be creating a different grouping for region.
Yeah, but it must be the
Yeah, again,
put it
again,
down,
that's again, yeah, very, very important, very useful.
situation and region level, like 2 levels.
I think one problem that we will, and we have there already with some limited data that we have seen, is that, yes, you can have all these key indices, key information available per different health board in Scotland and so on. For example, different sub-region, but then it's not available by all the other factors that we have here. It's not available by age, it's not available by year, it's not available, well, not all of them together. Not so. Age and gender will probably be.
Yeah, that doesn't change.
Okay.
This
The idea
idea,
to a region. So it's just, I think it's just a different way of grouping, and it might not be exact, but it should, if you're grouping it into like good performers,
Yeah.
mediocre and poor.
This might work. We're still looking into. Thank you. Very good ideas.
That's tiny question.
Yes,
I was
please.
wondering, is there a way to measure on the data the real experience delay in age diagnosis what occurred in 2020? And we can already, well, we'll be ending.
So I think, yes, there's more data now.
There is data now, there are data, I mean, there is information that people have used. There are publications actually about what this delay has been. Again, it's on an aggregate level. It's not by detailed grouping that we want, but
and gender.
I mean, some of the scenarios that we started with some time, a long time ago, was roughly, so they were roughly based on what we have seen in real life and publications.
Yeah, such information in the macro modeling, but by looking at the decreases by age, gender, there.
In concretely, I mean, what are the numbers? I mean, is it more in the range of 1 month or 6 months? What should we expect?
No, it's between, I would say it's closer to 6 rather than 1 month.
Yeah, it's not that short.
So the publications we've seen, they are based on, again, scenarios that call on real data showing 6 months delay. So
it's just easier to find some information about the drops in cancer registrations rather than the delays in diagnosis and tendencies, creating a lot of scenarios.
yeah, but the other thing that you mentioned earlier is important as well, because we're talking, if we are talking about a 6-month delay in diagnosis, this happened in 1 year in 2020. Then the rates of diagnosis, they went back to more or less the usual rates in the later years. So that's the important thing. We're not talking about a 6-month delay in each single year, because that would have been huge.
Because although you might have had a delayed diagnosis, yeah, then they all got their hands slapped and told to behave themselves and they started to do better. But they haven't been able to catch up on the time to find out you have cancer, but then you're waiting for how long to get treatment.
Yeah.
And that you might as well not have the diagnostic for the change in mortality.
Yes, fair.
Yeah, that's also very interesting. You're right. I mean, there was a very big drop in referral times as well during the first year of the pandemic. At least in Scotland, where I've looked at the data, then it did go up again in following years, but it's still far away from the targets, whatever targets the government has. Yeah.
They're doing okay. Like first year, absolutely slipped,
Yeah.
and then some of them came back somewhere pretty close for diagnostics, but not for treatment.
Yeah.
And some of them caught up better now, but some of them are still lagging.
Yes. Good.
So shall we move on? Yeah.
We take 4 questions and then we have action. For the later part, I think the action you can.
Okay. Okay.
How about it?
Yeah, well, that's fine. So you want to stop here, then? Or do you want?
Any more questions? We can still discuss for another 5 minutes question.
Okay, so we'll do the rest.
Only, I mean, if there is still the first part, I mean.
No, this is now about new data. And
Okay, about the new data
Think
and
about later.
research teams.
Yeah.
If no more questions, we can prepare for the lunch. So we'll be here, there will be, I think will be, right outside.
Yeah.
I will have people joining online and you will come in for lunch.
You were online last time. I think last week, actually.
My big perspective on is usually.
Hello, for those online, you can still come for lunch. We have some opening slots.
If I have to give them. The models they develop start with on the
Yeah.
and then development over time. Situ then detected, undetected, screening,